In recognition of New Zealand being a bicultural nation and it being Te Wiki o Te Reo Māori, or Māori Language Week back home at the moment, I'm going to start today with my pepeha, which is a Māori introduction when meeting new people and when speaking to groups such as today. And to acknowledge our multicultural attendance here today, I've provided the English meaning on the slides. Ko taupiri te maunga, ko waikato te awa. Ko naruahia ki te turanga waiwai. No kirikiri roa ahau. Ko ahau te kaiwhakahaere o te nehi mo Southern Cross Healthcare. Ko Carey Campbell, tuku ingoa. Nō reira, tēnā koutou, tēnā tātou katoa. In Māori culture, it is also customary to acknowledge those who precede us and those who have passed. Therefore, it is only right to acknowledge again the passing of Her Majesty Queen Elizabeth II and note her exceptional leadership and service over such a long time. I have so enjoyed hearing the anecdotes of her sense of humour over the years. Moi mai rā, which translates to rest in everlasting love. It's very apt. You will have worked out by now that I'm not from these parts. Orion Health have very kindly brought me over from New Zealand to speak to you today. Together we have done some fabulous work over the past few years, and I've been told we've achieved things many have not. Our partnership has led to a very successful program of work enabled by Health IT. Even though some research says that 40 to up to 70% of IT projects fail, we've been successful. So today I will share how we were successful. It's very humbling being in the presence of health leaders such as yourselves, and I hope that what I have to share excites and inspires you as much as it does me. But firstly, let me tell you about my organisation. Southern Cross Healthcare is New Zealand's largest private healthcare provider, which has as a major part of its business 10 wholly owned and 6 joint venture partner hospitals across the country, from Invercargill in the deep south up to north of our largest city, Auckland. Our newest hospital is in the very picturesque tourist mecca of Queenstown. And as you see, it's stunning and a great place to work if you're looking for a new venture. Our hospitals, and there's 3 ski fields very, very close, and just behind the building, so that's the hospital there. It's very, very modern. It's a beautiful hospital inside. And behind that is the beginnings of the Remarkables, which is a great mountain range and ski field. I'm not a skier, but you can imagine that picturesque. There's a big picture window out of the day stay where you're looking straight at that mountain, and covered in snow is going to be stunning. When I first started at Southern Cross Healthcare 14 years ago, there were no specific electronic clinical systems. We had a PAS, which was focused on booking and billing, with a couple of clinical admin processes thrown in for good measure, bed allocation and a really crude allergy and alert system. In New Zealand, we are lucky that we have a National Health Index, and our PAS links to that for patient demographic data and some national alerts, but that was about all we had electronically. Luckily, we had a couple of visionaries leading our IT department back in the day who had the dream that we would move from a fully paper patient clinical record to an electronic patient record, and we'd do it in 7 years. They chose Orion Health as our partner. We rolled up our sleeves and got on with the job. Luckily for me, they wanted me to be the business owner of the project. I say luckily now because I wasn't so sure at the start. I said, I can't do that, I don't have the skills. They disagreed, and I got suckered in it for the long haul. Their mantra always was, and still is, that implementing an electronic patient record is a business change project enabled by IT, not an IT project. I didn't really understand the importance of that, but important it is. However, the word business was still a bit of a stumbling block for some nurses, as when we, as nurses, hear the word business, we generally think commercial. One of my first impacts was to interpret business to mean something to nurses and to reinforce that as the Director of Nursing, my focus remains patient care. So when I talked to nurses in the initial stage of the project, we stressed this was a business change project, and as nurses, our business is patient care. A major part of patient care is, of course, documentation. This was another important use of language. The naysayers often brought up the fact that digitising the record meant that nurses were going to be used for data entry. It's really strange how using a keyboard as opposed to a pen and paper turns clinical documentation into data entry. But language is important, and we really focused on using the more accurate description than the one with the negative connotations. So what do we have today? Nearly 7 years after the pilot at our first hospital that started on the 2nd of February 2016, and that date is etched in my brain, we have 16 geographically spread hospitals using our electronic patient record and clinical administration functions, known to us as Clinical Workstation. And we use it, or the nurses use it, for every patient, every day. That was our mantra, every patient, every day. We have dynamic dashboards with cards that act as entry points to many functions. We have new features like docked windows that enable 2 or more views at once, and you can also add or edit data in either of the windows. We have eVitals that incorporate our New Zealand early warning scoring system for patient deterioration, linked to our sepsis and sepsis bundles of care. Not only are the eVitals viewed as a trending vital signs chart, as on the screen here, but the total of the early warning score and the trend surfaces on the ward whiteboard. Clinicians can see the whole ward or hospital, depending on the size of the hospital, at a glance with the colour-coded score and the trend line against each patient. Here's a close-up for you. There's the ability for nurses to add a comment to vital signs as well, like blood transfusion start, blood transfusion end. We have a kitchen whiteboard which is invaluable for communicating meal requirements and food allergies to our kitchen staff. This used to be a very manual, paper-based process that often caused us grief during our Ministry of Health audits. Once we had the kitchen whiteboard, which is updated every 30 seconds with any new or altered data, our patient safety issues decreased hugely, and we didn't get grilled by the auditors as much. We also have a theatre whiteboard which updates with any changes to the theatre lists and is linked to our theatre times. The patient data miraculously turns green once the patient is knife to skin, or as we know it, theatre start, and stays green until theatre end, or once the dressing is on. Once the patient leaves PACU or recovery, to return to the ward or day stay, the patient data leaves the whiteboard. For those of you who love lists, you will appreciate how very satisfying it is to see the theatre whiteboard get smaller and smaller during the day and then empty at the end of the day. We also have progress notes with a number of different templates to suit different users. So we have SOAP or SOATAP for physiotherapists, an interim theatre report for surgeons. Comments on lab reports also surface within the progress notes, as do any vital signs comments made. So this ensures that no commentary is missed and it remains in chronological order so that the patient's story is complete. The visit summary tab not only displays current and previous visits to a Southern Cross facility, but it links to our national NHI system and displays all visits to our public hospitals and other private hospitals who provide their ADT data to the ministry. This has been invaluable for clinicians to piece together a better history, particularly for those patients who aren't very reliable historians. An example recently was a patient who had had previous visits to the public system for seizures. The patient had forgotten to add that information to tell us, but we could see that the admissions had happened. Our anaesthetists and pre-admission nurses love the NZ EPS link. That's a New Zealand electronic pharmacy system link. This provides a list of all medicines that have been dispensed by New Zealand community pharmacies. So of course this doesn't necessarily mean the patient is taking the medication, but it's a very robust source to kick off a medicine reconciliation on admission. I could go on and on about the features and use cases within Clinical Workstation, but I'll stop there. I need to get onto some aspects for you that made this a success for us. There's quite a few, with some being earlier on in our journey and others being more recent. I'll start with some of the key principles that are in addition to the given that strong governance is an absolute requirement, with support and buy-in from the highest level of the organisation to make this a success. So these are the 5 key principles I'll just go through, and I've already stressed the first one, that this was a business change project, not an IT project. Second here is keeping the patient at the centre, and this may seem a no-brainer or even a cliche, but it is an example of how we have used that well in our clinical assessment process. So historically, there were different paper forms for the different disciplines, like nursing pre-admission, anaesthetic pre-op assessment, physio, OT. When we were designing the physical assessment part of our clinical assessment process, we made sure we didn't have separate, say, airway assessments for different clinicians. We use standard accepted frameworks and have one assessment that any health practitioner who has the requisite skills can complete or add to. Being electronic, of course, it's very easily updated with an audit trail of who did what, when. It's easy. We stress that any increase, number 3 here, we stress that any increase in work up front was acceptable when there were downstream benefits. This was important in our initial rollout, as there was the possibility that the work required at pre-admission and admission may actually increase to start with, especially when they were learning. So we reiterated that this would provide time saving during other parts of the patient journey. And it did transpire that all the work up front helped to pre-populate the data in the e-discharge summary, so that they didn't have to put that in again. However, this was only truly accepted by our clinicians when they actually experienced it themselves. They didn't believe us. They had to experience it, and they did. It was important to us that our patient record incorporated the doing, not just the viewing of patient information. A number of patient records in New Zealand focus on viewing data, but still require the clinicians to document new information on paper. Our aim was to have a paperless patient record, so we needed the doing. Together with Orion, we made this happen. We also needed to ensure the products were configurable to align with workflow. Mark Rainford, you drilled workflow into me right at the beginning. It can be a bit contentious at times, but choosing a product that can be moulded to fit how clinicians work is so very important. It can be a fine line though. Whenever we got to a point where we were moving too far down the config path, we stopped and started our thinking again. Too much config isn't great. When the balance is right though, the electronic patient record becomes a tool to support clinical work as it is done. Instead of documentation being an extra chore that has to be done, often at a later time, duplicating work effort and adding in the risk of interruptions or forgetting to go back and add it in later. It's a real patient safety risk doing that. Not aligning the electronic patient record to workflow runs the huge risk of our staff taking unsafe shortcuts and implementing workarounds. Many of you will have, or you may have heard the saying, where there's a nurse around, there's a workaround. Us nurses are great at developing other ways of working when the rules don't match reality, supply doesn't match demand, or goals, like being efficient and thorough, can cause conflict in real time. Research shows that workarounds in healthcare aren't generally developed through laziness, which is good. However, there is some research that indicates an escalation of workarounds at times with the introduction of electronic health records. Workarounds in life are often fondly referred to as life hacks. And when writing this presentation, I came across a technology life hack which helped me instantly. My keyboard had a broken foot, and I was using a booklet to hold it up, but along came the bulldog clip idea, and it's fantastic. So you actually take the little thingy off and you can clip it into the back of your keyboard and it holds it up. It's fantastic. So I knew I should just get a new keyboard, but I'm a nurse, so I love a good workaround. So I thought I'd share this with you today in case, in the future you need to actually hold up your keyboard. So building on the 5 principles that set us up for this project, I want to share our key success factors. And I've split them into 2 sections, the initial rollout and then our ongoing work. So for our initial implementation, planning and design was a real focus, including the use of accepted clinical frameworks, examples such as the Braden scale for pressure risk assessment. In New Zealand, we also link with our National Health Quality and Safety Commission for national and international best practice. And we use Te Whare Tapa Whā, which is a Maori model of health, as our foundational framework, which is an holistic health model incorporating all dimensions: physical, emotional, spiritual, and whānau, or family. It has held us in good stead to date. We kept a focus on our language to ensure the correct messages were still getting through. Nurses were assessing patient information and documenting this electronically, not mindlessly inputting data. So we constantly reiterated that. At each hospital, go-live preparation was robust and included, amongst many other things, pre-site visits to understand the local nuances in custom and practice, and to forge strong relationships with all levels in the hospital. Just-in-time training was on-site in pop-up computer labs. The logistics of transporting equipment and setting these up was managed so well by our wonderful IT experts. Our training was role-specific, with the training system being set up specifically for each session. Our trainer kept herself entertained using some very innovative names for the made-up patients in our training environment. If you Google names with innuendos, see what you get. Some are a bit risque, and we had to review those in time and keep her in check. One of the most valuable support for our staff was the strong presence at Go Live with our on-site support team. I was amongst them, of course, because there's no show without punch. We had teams covering each shift in each area, working alongside our clinical staff, guiding them. We took some of our clinical staff from previous Go Live hospitals as well, which really helped with credibility, amongst other things. After the initial phase, one of our key success factors was moving into our innovation partnership with Orion Health. This was a real step up from our original working model, and was really when things stepped up a notch and we really got going in speed to production and value to the users. The individual partners have a great respect for each other's skills and abilities, and a real understanding that together we are stronger and more successful. There is real trust within the team, which I believe really sets us apart from many other teams. With training and coaching for everyone on the combined team, we really embraced the agile principles and practices, including co-locating our dedicated team and ultimately adopting a two-squad model. We ensured we were open to new products and adopted them wisely, critically reviewing their value for our use cases and working alongside developers to ensure the right fit. Getting developers and nurses together in a room forged some really great discussions and many aha moments. Acknowledging the huge impact of business change and quantifying that for each release is really important to ensure the correct go-live strategy is used. This was done as a team, with me as the business change owner or clinical lead, leading and authorising this. Principles behind our decisions quickly developed, and we have attempted to document these as a framework for future use. You won't be able to read it now, but just trust me, we've documented it. But how did we know if what we were implementing was a success with our clinical users? Remember, we have 16 hospitals geographically spread from Invercargill to North Auckland. We have developed a Southern Cross Healthcare user acceptance scale, which, although it's very unscientific, is based on the scientific algebraic equation of inverse proportionality. And you out there will know it better than I do. But we have endearingly named it the Carey Calls Acceptance Scale. So very simply put, over the past couple of years, we have learnt that the number of phone calls or emails to me after we have introduced any new functionality is inversely proportional to the user acceptance. So if I get heaps and heaps of calls, we mean there's lots of problems. And when I don't hear a thing, it's success. You probably can think about how that's happened with you in the past. You only hear when people are complaining. So yes, we are successful, and the factors I've covered have all played their part in this success. However, one of the biggest game changers has been the move to mobile responsiveness. Using your mobile phone or small form factor is expected in our lives today, and someone mentioned it before, though it seems to be slower to emerge in health. At a user level, this has enabled our ward nurses to now pick up a hospital mobile phone at the beginning of their shift and have the patient record in their pocket and ultimately at their fingertips at the bedside when they need it for viewing and doing. It started with our eVitals development and implementation, and just on the first day of the pilot for that, with the first nurse going into a room and documenting the electronic vitals, she walked out and said, "Oh, I'd love to put in a progress note on the phone while I'm there." So we didn't have to force new functionality after that. The users wanted it and we sort of couldn't keep up, but we did. So moving to being truly mobile was the game changer for us, also with our medical specialist adoption. And remember, we work with surgeons and anaesthetists. I won't say any more. So prior to the patient record being accessible remotely on their mobile phones, our doctor adoption was slow and laborious. In Southern Cross Healthcare, we don't employ doctors, they bring patients to us, so they're like contractors. So yes, the adoption was very challenging. Multiple barriers. Some clearly stated to us they would not use it until they could access it on their phones on the run. So we've done that, and we now have well over 80% of our medical specialists signed up with more and more active users every month. It's not perfect yet, but it's a real improvement. One of the real drivers for our nurses to have a mobile phone-sized device was to prevent this workaround that nurses tend to use, and if there's nurses in the room, you'll probably have done this in the past, the paper towel trick. So the paper towel trick is when you're in the patient room and you haven't got the chart, whether it be paper or your computer from electronic, and you need to do the patient's vital signs. You do them, and you grab a paper towel and you write them on there. Or I think ambulance officers write them on their hand, don't they? And we didn't want the paper towel trick to happen. It's a real patient safety risk. There's duplication, time wasting, potential for interruption, and forgetting to then go back and put the vital signs in. So the mobile phone has been our saviour. And I can't put my hand on my heart to say that this doesn't happen anymore in our hospitals, but there isn't any reason to, because the nurses have the phone in their pocket. You can pull it out. So, what's next for us? All these things. Someone else said before, we thought we were there, but there's always more stuff to do, always more stuff to do. We're going to do more observation charts. So the fluid balance chart, which notoriously, internationally, is one of the worstly documented as fluid balance. So we're going to fix that. Neurovascular chart, blood glucose. Post-op care plans, we're using the checklist, Orion's checklist product for that. And we're just about to start a pilot with that now. The recovery record, which will mean in PACU it's totally electronic. Medications, which is charting, and the electronic medicine administration record. Smart search and eAdmissions, and I'll talk about that in a moment using Orion's digital front door. So Smart Search is a project where we're going to pilot a search capability with natural language processing, SMARTs, blended with an existing product. It's kind of a Google of the clinical record, in layman's terms, I suppose. I understand there'll be more about this in other sessions by people in the audience who know a lot more about this, because we're just going to pilot it shortly with Orion. eAdmissions pilot. We needed to improve and modernise our patient experience with the initial capability of enabling our patients, or our future patients, to complete their admission forms electronically. With our strong partnership with Orion, it was only logical to explore their digital front door technology. We kicked off with a small group of 6 surgeons in one of our Auckland hospitals. The pilot was a success, and we exceeded all of the targets. 91% customer effort score, which apparently is a measure of the ease of use. We had 90% adoption rate. Our patients were offered either digital or to fill in the forms on paper, with the number of users exceeding the required 145. I don't know how they came up with that figure, but I think it was the amount of, only with 6 surgeons. Because of this success, we are now planning the rollout to the rest of our network. And this is Jenny. Jenny was one of our eAdmissions advocates, dispelling the myth of older people not being able to use tech. She's 70 years young, as you can see there. So we've got a big program of work ahead of us, and that's really exciting. And nearing the end of my session today, I acknowledge that you are all on your own organisation's digital journeys. So I'm sure you'll find some truth in the 5 tips that I'm going to share with you now that I would give anyone embarking on a journey like that now. Embrace disruption, because disruption there will be. Be bold and brave. Choose your team wisely, and I added this next bit, and then get out of their way and let them do their work. This picture here is some of the clinical workstation team, both Orion Health and Southern Cross, in front of this beautiful home that we've said that's our co-located facility in Auckland, which is just behind one of our hospitals. A lovely home, lovely place to work. And as you can see, they do have fun. Hei tangata, hei tangata, hei tangata in Māori means it is the people, it is the people, it is the people. And that is the answer to the question of what is the most important thing? It is the people. And we're here talking about IT, but it's all about the people. Someone has to act as the interpreter between the clinical people, and the IT people, because we speak different languages. So I started being that interpreter, and I think some of the IT people were cringing when I was saying, oh, you know, it's the pipe that brings in the messages into the hospital, it's too little, and things like that. And the nurses were going, oh, I get that. And yeah, people were shaking their heads, but you know, we do have to become multilingual. And my 5th tip, which I didn't steal from you, really, when I saw your presentation there on LinkedIn, we've got to have fun. And more fun. This is Gina, our trainer, and every time she went into a hospital, I had to sort of keep track of her. She's not a clinician, and she would get it up to mischief. She loved wearing scrubs. There was a photo of her in one of those orthopaedic hood things, pushing trolleys down. Oh, whoop. She used to zoom along on the bed movers. Health and safety risk, but we had a lot of fun. And so on that note of fun, I'd like to finish off with a poem. And it's a parody of a Dr. Seuss poem that I wrote during our electronic patient record rollout to demonstrate the importance of our people and the growth mindset needed in all that we do. And also how fantastically that our clinical staff managed this large-scale practice change. So here goes. I am Fee. Fee is me. I do not like technology. Would you try it just for me? No, I would not. Let me be. You can use it here or there. I don't want it anywhere. Come on, Fee, humour me. You can do it. You will see. We have training. It's for free. And we'll pay your salary. We'll be with you all the way with every patient every day. Everywhere I look, I see that project team is hounding me. And so that I don't look too dumb, training session, here I come. I'll join in, I'll play their game. I'll have to get a username. And I'll need a strong password that's memorable, but not absurd. I see. It's not too bad. It's here to stay. It's not a fad. From me, the training gets a tick, because I improved with every click. My resolve is getting less. Should I tell, should I confess that what I've learned is really brill? The key to this is will, not skill. I am Fee. Fee is me. I just love technology. It's part of work. It's not a chore. My request is give me more. So don't be scared. You know what's true? If I can do it, so can you. Kia ora, ngā mihi, mō te whakarongo. Thank you for listening.